and which is trying to trouble the humanity in terms of recurrence, multicentricity, and then progression to muscle invasive nature. Now, we all know that cystoscopy is a classical. Now, cystoscopy is a hallmark of any detection of carcinoma of bladder. The patient with hematuria coming to us, certainly we will investigate and find out what exactly is the cause of this problem, whether we are missing any important condition like cancer, particularly cancer of bladder. Basically because once you detect a cancer of bladder, the person is going to stay with you probably for next few years to 20 years, as long as he lives. Because of the nature of the bladder cancer, it's the 9th most common cancer worldwide, but of all cancers, the most expensive cancer and most difficult to treat cancer is cancer bladder. 13th most common cause of death, and 3% of all cancer deaths in US. In India, in fact, not many of them might be diagnosed because patients may not come to you often, because once or twice they come to you, then they just use some indigenous medicines and then ultimately you don't know what happens to them. Even women also have CF bladder. Majority we used to think that mostly men are affected, but here women are also increasingly because of the exposure to the industrial carcinogens or changing lifestyles. Approximately 70 to 80% of bladder tumors are non-muscle invasive. That's a real problem because 80% are non-muscle invasive and 80% recur in next 5 years. If you diagnose a patient today, next 5 years, you keep on recurring, and then ultimately you have to find out whether it's going to muscle invasive. The real reason why we are trying to enhance the cystoscopy is our basic cystoscopy is not enough to diagnose all the tumors that are present at the time of presentation. That's why the topic is enhanced cystoscopy. How can you enhance cystoscopy to detect cancer more effectively and more completely, and detect carcinoma in situ, which is probably not clearly seen by a cystoscope with a naked eye or white light. Low-grade lesions like T8, T1 and carcinoma in situ are the most dangerous because we tend to think that what we see is real and that's complete, but it's not true. There are many things which we are missing, and probably they are the cause of the recurrence and the chronicity of the condition. Now, carcinoma in situ patients, how they present is not different, but gross painless hematuria, microscopic hematuria, urine cytology is not very effective because many times it's negative, though there is a tumor inside, and irritating voiding symptoms are the ones which probably bring the patient back to you saying that maybe there is a cancer which is missed in the initial cystoscopy. Now, if you see the staging wise, it's very important that non-muscle invasive tumor is different from a muscle invasive cancer, both in terms of morbidity, mortality, and behavior. If you see the urothelium, lamina propria, they are superficial, but once it invades muscle, entire scenario differs, and the death rate is very high. That's why we have to actually diagnose the patient at this stage of non-muscle invasive bladder cancer and see the grade of the tumor, because grade is important. Because grade is actually it dictates the recurrence rate. Coming to the tumor size, multiplicity, papillary or sessile, or there is a lymphoid invasion and all, will be actually diagnosed by other modalities like CT scan and other things. But as a urologist, first thing what we are doing is cystoscopy. Urine cytology we do, but many of the times in a low-grade cancer it is not actually possible. Upper tract imaging also is done because bladder cancer can be associated with upper tract lesions also. There can be concurrent and simultaneous tumors. If you see the ultrasound, this is a classical ultrasound where we are seeing that there is a space of lesion, probably bladder cancer. It sometimes is sessile, sometimes it's solid, sometimes papillary, sometimes multiple. Ultimately, there are all hypoechogenic masses which actually take us to cystoscopy. Coming to cystoscopy, once we diagnose a tumor, we are doing a biopsy. And biopsy, we are waiting for the biopsy to know whether it's high grade or low grade, whether we have gone up to the base, and then planning our treatment. CT scan is for basically for tumors which are actually muscle invasive or more extensive, which look solid or high grade. Now, MRI also is helpful in patients where there is a large tumor, we are planning a ablative or a radical surgery. But coming to to the white light cystoscopy, which is the main topic. You see the cystoscope, there is a red background. This is the blood vessel pattern. We all know every urologist enjoys the velvety appearance of the bladder mucosa, the vasculature, which is classically pleasant to see. But when you see something which is not actually visible to the naked eye, that's when you get surprised that as surgeon we are missing many things. And how can you diagnose that? That's called photodynamic diagnosis and narrowband imaging. These are the two microscope modalities which can tell you where you are missing a bladder tumor or the multiplicity has been lost. You can see here fluorescent cystoscopy. We all know that white light cystoscopy can miss about 30 to 40% of the tumors. What is fluorescent cystoscopy? We give porphyrin, hexaminolevulic acid, and then you see the difference between the normal white light cystoscopy on the right side and the left side. We are showing a tumor which is much bigger, which was not detected by white light cystoscopy. If you miss this, patient is in trouble because it comes back with multiple tumors or muscle invasive tumor much later after a few years. You really don't know. Probably you think that this patient had muscle invasive tumor, but few years back some urologist somewhere has missed a superficial bladder tumor which could have been seen by an enhanced cystoscopy called photodynamic diagnosis. You can see here how a white light cystoscopy on the left side looks normal, or maybe there is a little bit of hyperemia, hypervascularity, but actually if you go to the photodynamic diagnosis, it's a carcinoma in situ, it's extensive, which could have been missed. And if you know this, the treatment entirely differs. Probably the morbidity and the treatment modality also will change. So fluorescent cystoscopy is a very good modality which is little bit of injection is necessary. You see the left side which shows that cystoscope shows only small tumors, one or two in the middle of the field. You would have missed the bottom one. The bottom one is not seen clearly. In the bottom there are two other small multiple and multicentric tumors which are actually clearly visible only with blue light cystoscopy. Now, how does it differ? It actually accurately demarcates the tumor from the mucosa and also aids in complete resection. If you see the tumor, you resect. I am not saying that urologist misses resection or improper resection is done. But if you don't know, if you don't see, you can't resect, and you can't resect up to the base or to the completion. Now, narrowband imaging is another modality. What is narrowband? Many people say narrowband imaging is very good, it helps. How does it help? The spectrum we all know, VGR, violet to the red color, it is 380 to 740 nanomicrons. What we are seeing is the white light is having a bigger band, whereas narrowband is somewhere between 415 to 540. That is middle of the spectrum. There is blue and green light. If you use that, you see more tumors. That means in the VGR spectrum, we are going to the narrow portion, the middle portion, and only little bit of the light. The upper one is blue light, the lower one is green light. If you actually focus these two lights onto the tumor or to the bladder mucosa, the hemoglobin absorbs these two better than the whole VGR spectrum or white light. So narrowband has got blue and green lights only, and if you see on the website, there is only a streak of hyperemic area. By narrowband, it is showing differently. It is showing as brown or green. The superficial vessels are seen as brown, and deeper vessels are seen as green. When you see such hypervascular things, you have to actually be more cautious and find maybe we are having a tumor there, and this hypervascularity is because of the tumor or a carcinoma in situ. How clearly you can see is shown in this next slide. You can see on the white light, it looks a little bit of small dots in the middle of the field, but if you see in the narrow band, everything looks green because we are actually using blue and green lights. You can see brown is the superficial vasculature and green is the deeper vasculature. And certainly you can see the tumor there, you will dissect and make a diagnosis which is much more accurate, much more extensive, much more complete for the patient's cure. You can see narrow band, another one. The left side shows only little bit of blotch of a hyperemic area, but if you see there is a tumor which is a carcinoma in situ, later it grew to carcinoma in situ, and lot of hypervascular area which could have been missed without narrow band. How is it done? It is with a Olympus machine where it has got a narrowband button. If you press the button, only blue and green lights will come onto the tip, and then this is how it is seen. There is no pigment, there is no injection, there is no fluorescent, no invasive procedure. Simply pressing the button on the machine, and then you see the things in a different way and try to increase the detection rate. You can see another one on the right side. You see a polypoid tumor, but the base and the vascularity, you can see more extensively going to the periphery of the field. That only shows that not only you see the tumor, but you can see the extent and where actually the vascularity is coming and how extensive, how much you have to go. The margin of the tumor where you have to check also can be dictated by the narrowband imaging. Now it is actually false positive rate is a little bit around 10 to 40%, but ultimately they found that more than 40% of carcinoma situ were detected on narrowband imaging. Coming to the next procedure, which is a medical wonder, optical coherence tomography, where it's actually with a cystoscope you are doing a scanning. It's called optical scanning. We know that when you do ultrasound, you see the lines, you see the depth, you see the abnormal areas. Similarly, with the tip of the cystoscope, we are trying to see the tumor and its base. How is it done? You can see on the top we have shown that is mucosa, second is lamina propria, and third is muscular propria. The tumor is here on the right side, but you don't know how much depth it is there and what is the extent on the side. With this technique, actually, you can go up to 2 millimeter below the surface of the tumor or the mucosa, and then 2 centimeter lateral to that. So it is like a beam-mode ultrasound scan with the optical light, which is a wonder because with the light you can't see the depth. Whereas in optical coherence tomography, we are using a laser beam to see the depth of the tumor, how far it is there, and in this line you can see whether there is a invasion of the muscle or invasion lamina propria. On the top we have seen that the mucosa is very thin, there was invasion there, that's why there is a disruption of the line on the top. Coming to the bottom one, if you see all 3 lines are okay, that means the tumor is restricted to the superficial layers, and that's where our complete resection will help the patient. So in this we are trying to see that the level of the histology, what we go, or by scan or any other methodology, we cannot go up to the 2 millimeter depth, which is more important for the superficial tumor because if you completely resect, then the risk of recurrence is much less. The recurrence is high only because of lack of knowledge or lack of detection, or multiplicity is not understood, or carcinoma situ is not detected. Now coming to the another important confocal laser endomicroscopy. It is actually widely used for bronchoscopy, gastrointestinal tract, where they use an endoscope. It's a flexible endoscope. They go up to the tumor and then they see with a laser beam. You see the beam is hit on the mucosa, and what you see is the histology. You cannot imagine to see a histology on a laser beam. This probe is around 2.6 millimeters, and a flexible probe is available through normal cystoscope. What it does, so you can see here, when you see this light, we are seeing the cells. The cells also on the top of on the left side top, you see the cells are okay, they are normal, but on the bottom, the cells are abnormal. The nuclear atypia, the cytoplasmic nucleus ratio is altered. That means this histology is seen on an endoscope, which is just a medical miracle, because by laser beam you can hit the mucosa and the cells will be seen, and these cells will guide us to know whether there is a grade, what's the grade, what the extent you have to check, and what the extensive section is done only in the initial stage. If you miss the edges, the recurrence is the rule. That's how the confocal laser microscopy, you can see on the top, it's a malignant tumor on the left half, whereas you see on the bottom, the cells are okay. So, see the histology through a light of endoscopy or cystoscopy, enhanced cystoscopy is a real wonder. You can detect all the tumors what are available in the bladder at the first instance. If you miss on the first instance, every person who is coming after that will only think that the previous tumor area is a cause of recurrence, but where you have missed is shown on the confocal laser microscopy. This is a classical slide you see on the top, normal, on the left side, cells are okay, low grade urothelial carcinoma, which shows little bit of pleomorphism, but on the bottom, if you see high grade tumor which is having irregularity, the nuclear size is much bigger and the orientation, microarchitecture is actually disturbed. That's how with simple endoscopy through a cystoscope, using special probes, you can detect more tumors and the depth of the tumor, the extent of the tumor, 2 millimeter periphery of the tumor, so that excellent resection can be done and the recurrence can be prevented. And even if there is recurrence, you know what to do, whether to do BCG or mitomycin and how to follow up is actually guided by this confocal laser microscopy. So coming to the enhanced cystoscopy, we have got 4 methods. One is photodynamic study, second narrow-band imaging, confocal tomography, and laser endomicroscopy. All these 4 actually detect 90% of the tumors which would otherwise would have been missed by a white light cystoscopy, and hence enhanced cystoscopy has a great role. And it is not an experimental change, it is being used, it is FDA approved since 2014, and then many of our institutions might not have, but if the facility is there, certainly it helps the surgeon and the patient and ultimately the humanity. Thank you.